Good morning. Thank you first of all, Matthew, and I'm Virginia from the Center for Statistics in Medicine. I'm trial statistician for the Oxford Surgical Intervention Trials Unit. Today I will talk to you about the role of statistics in the running of, in the conduct of randomized control trials, and particularly about the trial design, and with particular reference on surgical research. So, first of all, I'm sure you already know the definition of an RCT, but it's a controlled experiment in a group of participants, in a series of participants, who are randomly allocated to 2 or more intervention groups. So, yeah, the word randomized, as I said, is because they are randomly allocated, and the word control, it's instead the fact that it indicates the fact that these 2 or more interventions are done at the same time, are basically conducted at the same time. And in the running of a trial, you need to consider several aspects, which, in a sense, they also reflect stages of a trial. So it goes from design, you need to consider funding, regulation, and we'll see with Victoria. So I will go over some of this because statistics is involved in at least some of this. So an ideal study timeline starts from an initial idea that triggers the research question, and so from there you decide the design of your trial, then you collect the data, then usually you pass it over to a statistician for analyzing it, and after interpreting the data, you then report it for publication or dissemination. So what many might think is that statistics is involved from the analysis of the work. But actually statistics needs to be involved from the very beginning throughout the trial. So to take all these elements that you just seen into more detail, the research question, it needs to be interesting, new, it needs to add to previous research, it needs to be ambiguous. What we mean by ambiguous, we can add to a treatment and say, I want to show this treatment is better, treatment A is better than treatment B, but what do we mean by better? You need to define what is better, so don't say better, that's ambiguous. And first of all, it needs to be one question. In many studies, it's not clear. It's difficult to identify only one question, but a design, it only answers accurately to one question. So the research question, it's also identified, and again, I'm sure you already heard about this, the so-called P code, which they identify the population you are interested in and where you want to run your research. What do you want to do for this population, and this intervention? So what do you want to do for this population? What are you planning to compare it to, and obviously what is going to be affected by this intervention? Sometimes it's also reported as P-code, and with T we mean the timeline, the time frame. So when are you measuring these outcomes? Then we have the population. So the population needs to be clearly defined, and it's defined by the inclusion criteria and exclusion criteria. So you start with inclusion criteria, you start broad, including patient. Don't forget to include like patient that you really want to look at. But then you exclude them, like so you narrow your series of participants so that you have a clearly defined population. But then of course you cannot have the whole population, and you need to have a sample that is representative of the population. But how many participants do you need to have? And that's when the sample size comes, and this is based on several elements and assumptions. First of all, it's based on the trial design and the primary outcome. And then you also need to decide the significance level, which is the type 1 error, and the power, which is related to the type 2 error. Specifically, it's 1 minus the type 2 error. And also, you need to consider the target difference. This is an assumption as well, because you need to consider the effect of the control group, which it's commonly taken from the previous literature or pilot study, if you do a pilot study for your trial. And also, you will need to have the effect. You also need to assume the effect for the intervention group. And this is related to this so-called minimal clinically important difference. This is based on two approaches. It can be an anchor-based approach and a distribution approach, but there is no gold standard for it, so its use is a bit unclear, but it's commonly used anyway. And then finally, also, the last assumption is the dropout rate. So, let's say a percentage of the participants that you think they might be lost to follow-up or drop out from the study. Then, in terms of intervention and comparison, these are often called, respectively, treatment and control. So, treatment can take different shapes. It can be a drug, can be a surgical procedure, can be a diagnostic test, and so on. And so the control, it can be standard practice, or it can be no intervention, it can be a competing intervention, it can also be a placebo, also in surgery, which is, you might find it a bit unusual, strange, but there are actually trials with placebo shunt surgery. Although they require ethical consideration and of course they require blinding, you can find, there's two references that I put in, but you can find lots more if you want to know more about it. Then the last two of the P code is the outcomes and the time. The main objective of your trial define the primary outcome, and of course you can also look at other outcomes, the secondary outcomes, but the primary outcome is really important because it's not just your objective, it's also what is required, as I said, in the sample size calculation. Then you decide when you want to look at the outcomes, so in short-term and long-term outcomes. So you decide your time point, but not all the outcomes, so not all primary and secondary outcomes need to be assessed and measured at every time point. For the secondary outcomes, they usually cover all aspects from efficacy, surgical, and symptoms, and in this case, it's important to include patient-reported outcomes and subjective outcomes if you are assessing symptoms in patients, and in this case, blinding. It's usually required if you're using patient-reported outcomes. Then it's also often they also cover the economic aspects and the safety. So for the safety, for surgical research, it's very common now, and it's I would suggest doing it to use the Klein-Dinger classification, which was developed based on the therapy that is used to treat the complication, so that this complication were ranked in an objective manner and in an objective and reproducible manner.